Recording in progress.
Characterization of the contemporary outcomes in lower risk patients. We took lower risk patients in the registry and find out that 95% had a 2-grade reduction of MR at discharge. So based on this, we've decided to consider transcatheter edge-to-edge in moderate surgical risk patients. Now, the objective of this study, it's called RepairMR, is to compare the clinical outcomes of MitraClip device versus surgical repair in patients with severe primary MR who are at moderate surgical risk and have a mitral valve conducive for repair. This is a prospective randomized multi-centered study to be conducted in the United States, Canada, and Europe. There are 500 patients going to be enrolled in this country. The two principal investigators includes Professor Pat McCarthy and myself, and every single case will have an echo core lab adjudication. This is the form of randomization. The patients will undergo have to be grade 3 or grade 4 by AAC criteria. They have to be a surgical mitral repair candidate. The surgeon has to agree. The subject is at moderate surgical risk, and the criteria is on the left side. The patient has to be 75 years or older. So anyone 75 or more, irrespective of the STS score, but is repairable. Or if you're younger than 75, the STS score has to be 2 or more, or there must be comorbidities. But the surgeon has to agree that he can repair the valve in a surgical candidate. And they get randomized 1-to-1 MitraClip versus surgical repair. Now, the primary endpoints are 2. So the co-primary endpoint, all-cause mortality, stroke, hospitalization, or acute injury requiring renal replacement therapy at 2 years. Any cardiac hospitalization in the first 30 days is excluded. So there's actually a blanking period in the first 30 days that won't count. The co-primary endpoint is a proportion of patients with moderate or less MR without the need for mitral valve replacement or without the need of recurrent mitral valve intervention, surgical or percutaneous, from the time of the index procedure through 2 years. In other words, if a patient has a replacement, that actually counts against patients. Yes. And so these are the secondary endpoints are the proportion of patients with mild MR at 30 days, length of stay. So this trial is ongoing at the present moment. There is another clinical trial called primary MR, which is randomizing patients TR versus surgical repair. This is actually run by the STS and as well as the CTNet trial. And here they are considering patients who are 65 years or older, all comers. And patients can be stratified as low, intermediate, or high risk. And they're being randomized 1-to-1. This trial is being run by the cardiac surgical group in the United States, which I personally feel is a bit unethical. This is another ongoing trial competing with the present study. So the MitraClip, it's time to demonstrate that the MitraClip is a reasonable option for selected patients of primary MR who are at moderate risk. And in the absence of data, it seems unreasonable to randomize a healthy low-risk 65-year-old patient with primary MR to clip versus surgical. But I think the intermediate risk patients will be followed for 10 years. So that means basically we think that our trial design is more rational than the second one. And I think these clinical trial patients will be followed for over 10 years. And this is, by the way, just what the concept of remote proctoring. I just want to show this slide that sometimes I do cases now in India with Sai. He's actually standing over there on the left side, and I can see the entire procedure on my screen. And I'm sitting on a laptop in my pajamas and actually controlling and discussing with him an entire case. This is where the concept of remote proctoring has started. Thank you very much.
And it's a real blessing to have Saibal looking over your shoulders, especially when you're attempting these nightmare cases. Hi, Saibal.
Thank you. I can hear you.
Thank you, all the speakers. We are running short of time, so we are ending session, sir. Thank you, Dr. Kar and Dr. Sai.
Thank you.
We will now run live from the Cath Lab at Rajasthan Hospital. Dr. Ravindra Rao, Chief Intervention Cardiologist and Chairman at RHL Heart Center, Jaipur, will now showcase a live TAVI deployment. I request the moderators for this session, Dr. Rajiv Bagarata, Dr. V.V. Bashi, Dr. Yugal Mishra, Dr. Shiv Kumar Nair, and Dr. Vijay Gupta to kindly take their places on the dais.
I'm going to stop sharing this, right? I'm trying to stop sharing, right?
Dr. Ravindra Rao, can you hear us?
Yes, sir, I can hear you.
So can we start?
We can start finally. So, may I know here are the chairpersons? Acha. Hello, can you hear me, sir?
Yes, we can. Loud and clear.
We also would like to thank the IACTS organizers for giving us this opportunity to do a live TAVI case. The only challenge is 20 minutes. Let me introduce my team. That's me, Ravinder. Here is Dr. Buddhaditya, Head of Cardiac Surgery, Dr. Pawan Mehta, Director of Intervention Cardiology, Dr. Govind Narayan Sharma, Dr. Prashant Varshney, who is a cardiac anesthetist. He specializes in all conscious sedation for all our TAVI and mitral clip. There's Neha. There's Sandeep, our Chief Technician. Edward's team there, and a whole lot of people will be helping us in this case. Let's go to the next slide. Next slide, please.
Also introduce the chairperson sitting here, Dr. V.B. Vasi, a renowned aortic surgeon, Dr. Shiv Nair, right, Dr. Vijay Gupta. Of course, you have Prashant Vaidyanathan, I'm myself, Yugal Mishra. So we are really excited to know about the case and of course the every step. Thank you. Move on.
We'll just take next slide. Next. So in 2021, we did 63 TAVIs and PMVR cases. We had zero intra-procedure mortality for TAVI cases for 1 year. Our in-hospital mortality was zero. Next slide. So we had patients who traveled from all across country. Next slide. This is today morning. This is our second case of the day. Today morning we did our 75th TAVI for this hospital and 200th TAVI for in Jaipur. Next slide. And this we also published our minimalistic TAVI outcome in Indian Heart Journal. Next slide. We compared our outcomes with the standard trial, partner 3 Evolute Notion, the stroke rate, the pacemaker rate, and all other outcomes are in comparison with what is published in Notion, Evolute, and Partner 3. The pacemaker rate for our cohort is 5.7%, mortality is 0.9, stroke is 1.8. Next slide. I'll come straight to this patient history. He's a 65-year-old patient, severe symptomatic aortic stenosis, NYHA class 4, peak gradient of 74, mean gradient of 47, mild MR, AR, aortic valve area of 0.2, severe LV dysfunction, EF of V1 is as smoker. He consumes alcohol and ECG shows normal sinuses. Can you play the echo? You can see global LV dysfunction. Play the next slide, please. You can see severe LV dysfunction, some RV dysfunction as well. And you can see on the right side, with that severe LV dysfunction, he still has a preserved gradients. Next slide. This is the CT scan. Annulus area is 663.5 mm square. Area derived diameter is 29.1. LCA is 16.4. RCA is 20. Good femoral vessels. Heavily calcified tricuspid valve. Next slide. Our plan is a conscious sedation TAVI, percutaneous TF, TAVR, 1 ProGlide, 1 angioc, and a 29 mm Sapien 3 valve. Next slide. Now let's show the previous angiogram. Let's go to the fluoro. Fluoro, please. Fluoro. Stop the presentation, please. Yes. So the coronary angiogram is normal. Next slide. Next. Next. Yeah. And you can see this aortogram. And you can next one. Next one. Yes. So you can see a heavily calcified severe aortic stenosis with grade 3 aortic regurgitation as well, and severe aortic dysfunction. So on the groin, we have a 6 French artery on the left. We have a 6 French vein on the left side. You can focus here as well. We have a temporary pacemaker, a 5 French pigtail, and a 9 French sheath. So we're going to go ahead and upgrade to a 16 French sheath, and this is where we are. So we have put one troglide in the right side. We'll put a 16 French sheath. Let's go. And then let's prepare a 9 French sheath inside the 16 French sheath. And Dr. Yugal Mishra sir and Dr. Prashant Vaidyanathan both are experts in TAVI as well. And so this is, we can have some discussion or questions if there's anything. So for this sheath, you can see this is an expandable sheath. Show us down, please. So when you put this big sheath, this is all the fluoro. Keep following the sheet. Let's put a 9 French sheet on this wire and an AL2 diagnostic catheter. So this is very important. You know, these when you advance the bigger sheets, this has to be under fluoro guidance. Because one of the important complications of a transcatheter aortic valve replacement is a bleed complication. Though that rate has come down because the device, all devices have now come down to 14 French. Let's put an AL2. So we have chosen an AL2 diagnostic catheter to cross the aortic valve. Can you show the hemodynamics also on the screen, live screen, hemodynamics please? So the audience can also look at the hemodynamics. We take a straight tip wire. Both. Show hemodynamics, show fluoro, and show our hands. So we'll try to cross with an AL2. Here it goes straight. And the way we were able to cross it is stenotic valve is you have to choose your catheter appropriately. Fluoro say. Show the fluoro. Yes. Now once the AL2 catheter is there, we would go ahead and put our exchange length normal Teflon wire. Okay. Go ahead and remove this. Keep the wire in place. And give me a 5 French pigtail. So this is a softer wire. Once you put a softer wire in the LV, you would go ahead and put a pigtail and we'll do hemodynamics. So the ACT, when we are doing a TAVI procedure, the ACT has to be around 300. We can also focus the way conscious sedation is being done. We already put a BiPAP machine for this patient. That's because it's got severe LV dysfunction and you don't want this patient to go into pulmonary edema during that procedure. Hold the wire, please. Again, so the wire has to be in the focus all the time. And here's the pigtail which goes, we'll go to the apex. Now we'll do hemodynamics. So can you see the hemodynamics? Can you have hemodynamics on the screen? Hemodynamics, please. So audience can't see the hemodynamics. उसको बोलना hemodynamics सिखाएं because it's very important. So you see the hemodynamics tracing, despite the severe dysfunction, this patient has got gradients. But I also want to draw your attention to the aortic diastolic and LV. They are so close to each other, and one of the reasons is significant aortic regurgitation and severe aortic dysfunction. And as a reason, the LV in this particular patient is around 33. So that's very important. So once the hemodynamics is done, we will take a stiff wire. If you can focus here on the camera, can you focus? Here on my hand. So you see, this is a pre-shaped wire. And this is Safari extra small wire. The pre-shaped wires, what they have done is they have decreased the incidence of LV rupture because in the past we would shape the stiff wire, and sometimes a knuckle in the stiff wire can go through the ventricle. So you can see how the wire is nicely placed in the ventricle. Now this comes out. Now either pre-dilate or not to pre-dilate. We have decided to do a pre-dilatation in this patient, and that's because it's a heavily calcified valve. And the idea to do a pre-dilatation is to create enough space so that valve can go through. But she's chosen a 23 mm balloon. That's the balloon, please. So sometimes you can also skip pre-dilatation, but what we have seen in our practice is if the aortic valve area is something like 0.2, it is better to do a pre-dilatation so that you're not struggling when the valve goes through the aortic orifice. Here's the balloon, and the balloon comes in, fluorosate. Okay, let's go ahead and pace at 180, please. So we pace at 180. The pressure goes down, go up, down, deflate. Okay, stop pacing. So you saw how the balloon milled down into the LV. So we're going to do one more attempt. Okay, we'll try pacing again. Okay, pace at 180. Let the pressures drop. Let the pressures drop below 70. Okay, go up. Okay, deflate. So you see, that's the reason why we're doing a pre-dilating. It's such a heavy calcified valve. So let's try at 160 and then go at 180 because the pressure is not dropping. So we'll try to cross again. Another way to do is you take a longer balloon, a 6 cm balloon, and do it. Okay, go ahead, place at 180 please. 160. Ramp up till 180. Okay, go up. Go. Okay, so the same deflate and stop pacing, please. So that's very important, otherwise you can see how heavily calcified the valve has gone. But at this point, a patient can also develop severe aortic regurgitation. But the way we prevent is the size of the balloon is smaller than or equal to the short axis. Okay, valve please. And now we know that when the valve goes through, we don't have to struggle at the level of illness of the valve. Okay, so here's the valve. It's a 29 mm Edwards Sapien 3 valve. So large element. Let's see E faces up. Keep a focus on the wire in the LV, please. Now, this goes through an expandable sheet. This sheet, from this, look at the wire in the LV. So that's very important. You have to keep a watch on the wire in the LV. So this is a 16 French expandable sheet where the sheet expands as a, okay, show me down now. Okay, show me both wire and the sheet. Nice. Okay. Fluorosate. Now what we'll do is push the wire in, go cranial. Yeah, this guy. So what we're going to do here, you can see the valve and the balloon, they are separate. So we're going to go ahead and pull back the balloon and mount the valve. Okay. So you can see on the screen how the balloon moves inside the valve. And we're going to do some fine adjustments again. And this is how the valve is setting up. So say, release one tension. That's great. Go LAO please. Push your wire. And you can see the device has got a flexion handle. Show the wire. Wire is very important. Show the wire also please. Show me down now. Okay. Now come to the deployment angle, layout 10. So the deployment angle is the angle where all three sinuses are in a straight line. Okay, so once the valve is inside, we're going to pull back the pusher. You can see this is very important. Pull back the pusher, come slightly forward. Let's just remove some parallels. Yeah, that's good. Okay. Ready for injection? Inject. So you see this valve is very high, so we're going to go a little. So you see picture is one point on the angular plane. So the way you want to position is, it should be something like 60-40. So 60 aortic and 40 ventricular to begin with, because the valve foreshortens from the LV end. Let's take one more picture. Inject. Yes, so that's a good spot to begin with. Let's come back a little. Okay, pace at 180, this is just a diagram. Pressure doesn't go down. Let's give some medicines to decrease the pressure, please. So that's very important. Stop pacing. So the pressure, the systolic pressure has to go below 70 before we deploy the valve.